Welcome to Inside Aesthetics, the world's leading podcast for injectors and aesthetic businesses. I'm Dr. Jake Sloane, an aesthetic doctor with over 16 years experience in facial aesthetics.
And I'm David Segal, an entrepreneur and business mentor with over 20 years of experience in our industry. Our podcasts are aimed at industry professionals, and any information or advice given is general in nature. You should consult with a healthcare provider before undergoing any treatment.
You can also subscribe to us on Patreon for on-demand content for injectable and business education.
Welcome to What is Trending in Aesthetics, and it's been a very salacious, busy week in the media land in relation to our industry, Jake. We were looking for guests to come on and talk about this, but no one put their hand up, so it's come down to you and I. And maybe just full disclosure from my perspective, and I'm assuming yours as well, is that we are inherently biased as pro-industry people. We both work in this industry. We're passionate about it. We've been in it for a long time. We think on the balance of good versus bad, the industry does way more good than it does bad.
Yeah.
So that's just full disclosure. Like, I do have a bias. I wanted to just disclose that up front.
Yeah, look, we toyed whether, is this an industry update, one of our new bonus episodes where we focus, I guess, mainly on Australian stuff. But I think this is a wider conversation. Now, some of the things that we're going to discuss have come from Australian newspaper articles that came out this week. But even just this morning, turning on my phone, I went on Instagram, and now in Texas, there's some potential new regulation coming. So I think this is a more broader discussion. This is more of a what's trending in aesthetics episode.
Yeah. What's trending is scrutiny, intense media coverage. We know we've got lots of regulatory discussions and changes. We had Jason McKaiser on from APRA not long ago. Hopefully he comes back soon to discuss some new regulations that are coming through very soon. But I guess we're here to unpack some of the stories that have been written and maybe just go through them and give our perspective. Obviously, there's been a lot of activity in our private WhatsApp groups and through various other communication channels. And people are obviously quite panicked. They're worried about their careers. We've fielded a lot of feedback from people who feel that some of the stories are not balanced, not fair, like some of the facts that have been written there, they're questioning. So I guess we're going to unpack all of that today. And whilst we are biased, try and be as unbiased as possible and just talk about the good, the bad, what we think the potential solutions are. And maybe we can even highlight some of the comments and Instagram stories and feeds that have been coming through in response to some of the coverage.
Yeah, and I guess just some more context of the planning of this. This has literally all happened in the last 5 days.
Yeah.
So as much planning as we can do whilst I'm working and whilst you're working, etc. But I did manage to contact at least one of the journalists of these stories. His name is Clay Lucas. He's an investigative journalist. He works for the Sydney Morning Herald, I think. And we managed to have a very brief WhatsApp conversation. I did want to acknowledge that, and I told him I would reference it, not in any sort of bad light, but I just want to try and get context before we plan this. Now, of course, I don't know the sources, and I don't really understand the focus of the three what are negative stories.
Yeah.
Nevertheless, I wanted to get the journalist's opinion before we, I guess, coloured this argument. And like you said, we're not trying to be biased, but I do happen to be a cosmetic doctor and you happen to be a cosmetic entrepreneur. So we have our inherent biases. But I like to think that we come at these podcasts pretty unbiased in the sense that we deliberately, when we're drafting our notes, we try and write both sides of the story. And even just you and me often come at things from different angles just because we're different people, and you're a lay perspective, I'm a medical perspective. So as balanced as we can, we'll try and discuss this topic.
Okay, let's kick off. The first story that came out was, I think it was called Gone in 52 Seconds, which was about telehealth and obviously focusing on one of the models here in Australia that's been very successful, which is Fresh Clinics. I'm quite sure they're the largest provider of telehealth medicine in relation to injectables in the country. I don't know what goes on in telehealth land outside of aesthetics. But essentially, the story was an expose on a consult that lasted 52 seconds, and there was a lot of criticism around how that took place. And then it was just a general perspective or opinion on that model and its place in aesthetics. Would that be fair?
Yeah, look, the full title was Gone in 52 Seconds, Inside Australia's Telehealth Injectables Gold Rush.
Yeah.
So even by the title, there's an implication that this is all dodgy and all about money.
Yeah.
So, So, look, I've got some bullet points here. Maybe I'll just summarize for our listeners who maybe haven't read it. Yes, Fresh Clinics were, I guess, exposed, if you like, in a 52-second consult. And essentially the point of the article is it raised concerns about patient safety and meeting regulatory guidelines. Now, we've covered tons of this in various podcasts. We won't go into it in too much detail. But I guess the implication is telehealth appropriate? How long should a consultation last? And is there a business angle to this that is negative and maybe the focus isn't on patient and is it on making money?
Of course.
Is that a fair summary?
Yeah, and it's a difficult one to navigate because whether we like it or not, money makes the world go. It's very cliche, but if there was no money in medicine, there'd be no innovation, there'd be no reason for people to get out of bed and be involved because at the end of the day, people need to provide for their families. And it's always a difficult one. And we've discussed this on the podcast many times. And some of the things I've spoken about is people that get themselves into difficult business situations and pressures to overtreat potentially or do things they wouldn't ordinarily do because there is that constant financial pressure. And it doesn't just happen in aesthetics. I'm sure it happens in all areas of medicine, really. Yeah. At what point does money start to influence medical decisions?
Yeah.
And it's to say it doesn't exist would be naive.
Yeah, look, just reading the title, that I guess the general public are immediately thinking, there's something evil about this or something greedy about this. But at the end of the day, a service has a price. It doesn't mean it's overpriced or underpriced. It just has a price. And that's how the world works. You go and buy a chocolate bar, you go and buy a car, money is transacted. Yeah. So yes, money is involved when someone calls up for a prescription, and that's just how the world works. Yeah. So I'm not really here to judge the price of it or how it works. It's more the quality of it, potentially. And we were talking off air and maybe this week, and someone said, okay, if 52 seconds is too short, what is it supposed to be?
And also, is it more about the time or is it more about the quality and what's discussed? I don't know the answers to those questions, but I don't think just using time as the only metric to what's good and what's bad should be what's used to arbitrate whether this is a good or a bad outcome. If you sit on the phone with someone for 5 minutes and there's nothing that's meaningful discussed or they fail to talk about potential risks, complications, someone that's inexperienced may take longer to do it. So I understand that 52 seconds might sound, oh my God, how can you have a conversation in 52 seconds? But I don't know. I wasn't on that phone call. Yeah. But I think I don't know whether there's enough context or information to say whether that was good or whether it's bad. I just don't know.
Yeah, and to give even more context, maybe there's lay people listening to this one because this is relevant for the public as well. We have new patients who come and we have, let's call them existing patients who come, patients who've already gone through multiple treatments before, they understand the drill, they've met the doctor before or they've met the treating nurse before. All of the questions have already been established. They know that they have no significant medical history or contraindications or allergies. And can be a very quick process. I'm not saying it should be sped up for the sake of speeding it up, but it can be a simple, you're back again. Has anything changed? No. Wonderful. Any new medicines? No. We're just going to reel through the risks again, which are bruising, swelling, ptosis. Are you happy to go ahead?
And blindness.
For tox in this context. And so I'm not sure why that would need to be 5 or 10 minutes. And 52 is just the number that it ended up on being. I'm not saying what happened was right or wrong, but there is context to this.
Sure. And then I guess maybe let's talk about other areas of telehealth that are used outside of aesthetics. So obviously you've worked in the public system here and overseas in the NHS.
Yeah.
So are you able to share any experiences around how these sorts of directives are given to nurses within a therapeutic medical setting?
Yeah, look, so I've never used telehealth in the UK. I don't believe everything was done, I guess, at best either through a phone, like a physical phone, or in one of my hospitals, it was quite cool actually, it was called a Versera. It's like a little, it's not a pager, it's more like a walkie-talkie. Anyway, a communication method. Now, I could be the on-call doctor having never met the patient on the ward that I'm being called about. And a nurse would call me saying, hey, someone's in pain. Can you give the authority to give paracetamol? And I'll be like, sure. Yeah. No problem. And that was the end of the conversation. Now, because they've already been met by a colleague previously and they've already done the history, checked them not allergic to it and so on. And so that's how it works in hospitals. And I haven't done a telehealth. I haven't inspected the patient through a video. I've taken the information over a phone and that's how things work in a hospital. Yeah. So in some respects, what this example of what Fresh have done is far and beyond what happens every day in a hospital. Yeah.
I guess maybe just to play devil's advocate and to look at it more critically, and if I put myself in the opposing viewpoint's position, we're talking about an aesthetic treatment. How meaningfully can you assess a patient aesthetically via a video image. Because the face is three-dimensional, there's obviously tactile things that might take place if you're doing an assessment. So I guess there might be some differences between giving a nurse an authority to treat or a prescription for a drug because someone's in pain versus assessing whether or not there needs to be a physicality involved to actually assess an aesthetic treatment. And I guess that sort of gets to the broader point. And I guess this is where maybe some of the challenges have happened is what are the expectations? Like what do the regulations say that needs to be done, or what are the requirements that need to be satisfied or met that then that allows the green tick to be put against that patient having that treatment? Because is it the nurse that's essentially leading the treatments that need to be done and the doctor's just checking from a medical perspective to make sure it's safe for that patient? Or is the doctor the person that's supposed to be leading that consultation and planning the aesthetic treatment, and the nurse is doing the directive that the doctor has given them? And I don't know whether we're clear on that.
And this really, for me, is the crux of the issue. And this isn't unique to Fresh. This is unique to all of the scripting companies. And I worked at LCA with you, where that was their model as well, with their own doctors and their own sort of telehealth system. That's the question, isn't it? If the doctor is there to essentially double check what's already been clarified in the history and the allergies and reconfirm the consent and not be part of the planning and assessment and touching the face, then it works as a model. If it is the other way around, where essentially the doctor is in charge of the thing, they're supposed to be looking at the wrinkles and the laxity and planning the filler and the units and everything, and the nurse is just there to do what the doctor says, I don't know how telehealth works, because you need that physical hands-on.
Yes. And it's not clear. The regulations don't, as far as I'm aware, don't stipulate down to that level of granular detail. And I guess taking that conversation one step further in terms of how nurses potentially work independently in other areas of medicine or nursing, are you able to talk to that at all? Are nurses able to make independent decisions? And how much autonomy do they actually get in other instances? Because I guess that will then, we could use that as a precedent to a certain extent to say, here are instances where nurses can make independent decisions, whether it be rural or nursing home. I don't know, but more about this than I do.
Look, we all work in teams, and a doctor is neither the best nor the nurse is inferior. That we work as a team, we all use our skill set to make decisions. For example, and Australia is very unique because it's such a massive country where we have rural populations and areas of need. That is how telehealth has come into its own. But we actually need it, because without it, we're blind and we can't see what's going on. And so from that perspective, I think telehealth is probably more leaned on here than maybe anywhere else in the world. I don't know. But certainly it wasn't a big thing in the UK because there's a tiny country and there's doctors around. But anyway, let's say you've got a community nurse and they're going to look at someone's diabetic foot in their house, and there's a change in the wound and maybe you might need antibiotics or maybe a different dressing. The nurse is obviously there inspecting. They are looking at the wound and they are the eyes and ears of whoever's at the end of the phone, whether it's a doctor or another senior nurse, and a decision is made based on the information relayed by the nurse. So by definition, the nurse is taking a history, examining, and will ultimately treat depending on the advice from the telehealth call. So it's not a huge stretch to suggest that the same model doesn't already exist with aesthetics, where nurse assesses, nurse talks, takes the history, relays that information to the doctor, and the doctor double checks it, summarizes, re-goes over the consent and says, are you happy with that patient? I don't see a huge difference, but again, this may come down to a real legal loophole that I'm not understanding, but it seems to work in practice in real medicine, if you like, or in the community.
And is rural nursing the only instance where this happens? Are we talking about like even, because we do have a general doctor shortage. I don't even know whether there's enough doctors around for all of the requirements that the medical system demands of it. But are nurses working more independently outside of just rural instances that you're aware of?
So I used to work at RPA, Royal Prince Alfred Hospital, and long after I left, I noticed they've established, it's like a community hospital in Green Square, which is near where I live, or near where I used to live. It's essentially a walk-in, let's call it an urgent care hospital, where you can go, you don't quite qualify to need to go to ED like a major hospital, but you need to be seen by someone. Now, again, don't quote me on this. I don't know if it's staffed by doctors or nurses. I imagine it's a mix, but there will be people there who are in contact with the main hospital where they'll use telehealth and other communication to triage people and get information to decide, is this serious, is this not serious? But they're using telehealth to assess patients and make decisions. So it's actually a great example of proper medicine, if you like, where the technology is used appropriately with doctors based elsewhere to make decisions about patients.
When you say appropriately, what do you mean?
For example, these people might be walking in with, I don't know, a major cut, not things like chest pain, they would go to ED. Things that are semi-urgent.
Yeah.
And by inspecting them and having nurses on the ground in the community hospital, you then link up with a doctor to make decisions. And that's not rural, that's in central Sydney.
Okay, where we have probably more doctors than anywhere else in the country.
It's flat bang in 5 miles from the middle of the city.
Yes, it's not rural.
So anyway, I don't want to make up examples, but this is fair game in major hospitals because communication's got so much better.
Okay.
We've got the tools now.
Okay. So we've established that there's precedent of this being used in other areas of medicine and seemingly no one has an issue with it. It seems to work. Technology is supposed to make our life easier, more convenient, make us more efficient.
The crux of this isn't so much what we've just said, but what has been shown to not go well.
Okay, let's give that some further context.
Because that will give us a window into, is this working or not?
Yeah, okay, fine. Let's unpack that. I've got this. We were talking to one of our, I guess, listeners, and she's actually been on the podcast before, a quite well-known senior nurse in Tamworth. Is Tamworth still considered rural? I think it might be, or
it's the
regional.
Biggest town in Australia.
Regional. Yeah, okay. And her name's Kelly George, and she's been on, as I said, she's been on the podcast before. Great reputation, lovely. She's been on the podcast before, and she actually did I guess it was almost like a satire kind of post on her Instagram, which got sent to me about 50 times yesterday by various nurses that we're in contact with. And we spoke to her this morning and asked whether she'd be happy for us to play this story, because I think it sums up the way a lot of people are feeling attempts to poke holes in some of these stories that have been written. So I might just try and find that to bring it up while you continue to chat and maybe frame the story a bit more.
Okay, as part of this story, I'm just going to read what was summarised on ChatGPT because I put all these articles through ChatGPT to make it easier for me. So, fresh clinics report around 1,000 complications annually, though most are mild. However, experts express concern that the rapid expansion of telehealth cosmetic injectable market prioritises profits over patient safety. That, I guess, is the crux of the argument here, isn't it? Now, 1,000 complications annually. Firstly, I don't believe they are fresh clinics complications.
But the inference is...
The inference is, exactly. It's the Fresh Clinics network that sort of is managing these. Now, I can say, and this is just anecdotal, I know for a fact that Fresh Clinics manage many other complications that have nothing to do with their network.
Yeah.
Because they have experience, because they've got the reach, because they're easy to communicate with. And they've done a lot of good to manage pretty serious complications like vascular occlusions.
And maybe let's point out as well that it's not just nurse complications that they're helping to assess and deal with.
And I know that for a fact, and I've spoken to doctors who have had the problems who Fresh have helped with. I know that for a fact.
Because I feel like this story has been, rightly or wrongly, targeted at nurses, basically in inferring or insinuating that it's nurses that are the problem.
Yeah.
And if you look at the numbers, maybe you could be convinced of that because the industry is dominated 80 to 90. The non-surgical space in Australia is dominated 80 to 90% by nurses. So it stands to reason that if there's complications, that the lion's share of those are going to be done by
9 out of 10.
Yeah, okay.
We've always got to look at proportion.
And is that mentioned in the article that them, I guess, looking at the numbers?
Not at all. I did actually ask Clay, the journalist, I said, obviously you can't give me your source or whatever, but is there a reason for the focus of these stories? Because at least for now, there's been 3 stories in 3 days, which are fairly negative about the industry. And he didn't really explain why it's happened now, but he did say there'll be plenty more to come because he's fascinated in the topic. So I don't know. Potentially he has a source.
Okay.
I'll note in the sources in just this article we're talking about, I don't believe there was a nurse commentator. I think all the people who commentated were the journalist himself or a plastic surgeon or a doctor.
And who was the plastic surgeon?
It was Mark Ashton, based down in Melbourne.
And is he an experienced cosmetic injector?
I have no idea. I can't comment. I know he's a plastic surgeon, but I can't comment if he's ever injected or...
Yeah. Okay. There are some plastic surgeons in Australia that are very well known for injectables. So our good friend and colleague, Dr. Stephen Liu, he's a very renowned and respected aesthetic injector as well as a plastic surgeon. He holds his own conference here every year, and he's someone that's hyper experienced. But generally speaking, most of the work that plastic surgeons do is surgery. There aren't a huge amount of them that have a lot of experience in injectables.
Yeah.
And so I guess if Mark Ashton, I know he's a very respected plastic surgeon, is he the best person to be giving, and this is just a question, not a statement, is he the best person to be giving an opinion on something that he may not have compared to someone like you, for example, who does this all day, every day? to give an opinion on that. I don't know.
Yeah, look, I've been called in the past by journalists wanting either interviews or random quotes or whatever, and to be honest, I've just stepped back away from there because of the way these things are spun.
Yeah.
It's never what you actually say that's important. It's how it's spun that's important.
Yeah, because I think the perception is, and I think I might have said this on the podcast before, that the term plastic surgeon somehow, for some reason, sits, or the perception is it sits at the top of the hierarchy of everything to do with aesthetics.
Yes.
And the reality is that they're not just, but they are one segment of aesthetics. You've got dermatologists as well.
Yeah.
And so, yeah, the reality is that most plastic surgeons don't do a heap of injectables. So I don't know on what basis their opinion should be, I guess, used.
Oh, it's just one opinion. Yeah. But I guess what I'm saying is they should have certainly got a senior nurse's opinion if you're going to write.
I guess that's the gold standard of journalism, isn't it? Is to try and get to be balanced and to get context and perspectives from both sides of an issue, potentially.
Yeah.
So I've got this story ready to roll. I'm going to try and just plug it into the microphone and see whether it actually will work.
Cool.
Patients are not safe at the hands of cosmetic nurse injectors. Oh gosh, why? What's happened? In the last 3.5 years, 16 people have had something go wrong.
Gosh, and how many people have actually been treated?
Oh, well, we're not going to tell you that, but it's obviously hundreds of thousands of people.
So hundreds of thousands of people, and 16 people have had something go slightly wrong, and all nurses did all of that?
Well, no. Only 5 of those people were nurses. The other 11 were doctors, but we're not here to talk about doctors.
Okay, so a really, really small percentage of people had something go wrong. What were those things go wrong? Were they like really bad?
Well, no, we're not putting that in the article either. We're not talking about those things.
Okay, so then 16 people have had some minor things go wrong, nothing permanent. So what's the solution?
Clearly, after speaking to nobody who actually does this really well and none of the patients that find this really helpful and beneficial, and only speaking to people that are anti-nurse and anti-cosmetic industry in general, clearly the solution is to not allow nurses to run these successful businesses anymore.
Thank you, Kelly.
Yes, thank you, Kelly.
Obviously, that's gone semi-viral.
Yes.
And I'm assuming all the nurses were sharing her on. Because it does probably summarise where most nurses are at the moment.
And also, to be fair, most nurses are terrified at the moment.
Yeah.
They don't want to poke their head up in case it gets smashed off their shoulders because they feel like they're under attack from every angle at the moment. So I think it takes someone quite brave to put that up.
Obviously, it's satirical, it's funny, it's scripted that way, if you like. We spoke to Kelly this morning. She gave her permission to put this on, so thanks, Kelly. She doesn't mention the 8 blindnesses that are quoted in this article that, to my understanding, have been reported over since fillers started in Australia. We've had 8 blindnesses that are known. Yes, Kelly doesn't reference the 8 blindnesses, but I guess her point is that the thousands of complications that are quoted in this article, when we actually drill down into what do we mean by a complication, it's anything from minor pain to minor swelling to minor bruising to blindness and nodules and the more serious stuff.
Yeah, or it could be like a dropped eyebrow.
Correct.
Or could a patient...
Self-limiting things.
I guess who's actually saying that this is a bad outcome? Is it the patient?
It's not bad. That's the point. It's not bad or good. A complication is just that. It's a complication.
Yeah, but who's saying it's a complication?
These are only reported complications, obviously.
And what's the source?
It has to be injectors or patients. It can't be anyone else.
Okay. But patients say things are complications all the time that maybe aren't complications. And maybe let's define that. What is a complication versus a known common side effect? So every time you put a needle in the skin, there's a chance, if you look at the anatomy, and I'm not a medical person, but I've seen enough facial anatomy charts over the years to know that there are literally like hundreds of thousands of vessels that you could potentially hit.
Yeah.
So is a bruise or swelling a complication? A patient, because often patients don't get bruises or swelling with tox. And then I knew this when I ran my clinics. You'd have a patient that's been coming to you for years. By the grace of God, they somehow have managed to not get a bruise or swelling, and then they get this one time where you hit something and they get a black eye.
Happens to me.
And then it's a complication.
All the time.
Okay, so is that a complication? Are bruises and minor swelling included in what's being defined as a complication?
Yeah, look, but by definition, I count that as a complication because it's something untoward that you don't want to happen.
Okay.
It doesn't mean that you meant to do it or you were good or bad injector. It's a complication. And so when you do a study, like a medical study for a new toxin, for example, all of these things are included, from pain to bruising to serious things. And we document those, and that's how we know that there's a rough ptosis rate of 1% for your average toxin.
Yeah.
Because that's how the studies are done. Sure. Look, worst case scenario, 1,000 complications annually, but including all of those minor complications as well.
Yeah.
You and I, over coffee this morning, we did this
Back of the envelope.
ludicrous calculation. We said, let's say there's 4,000 clinics here in Australia. I'm going to do it right now, live again. Okay, so 4,000 clinics, and
now we assume there's about 4,000 businesses. We're probably being a bit light on that, to be honest.
Sure, this is just plucked out of our head. Now, let's assume they're not that busy. They see 6 people a day. They probably see way more, but 6, that's the average. And they inject for, 5 days a week. They're not even open every day, 5 days a week.
Let's say 4 even. Let's be even more conservative.
Okay,
let's say
4. And let's say they give themselves a nice holiday every year, so they only inject for
48 weeks.
48 weeks. Yeah, so that comes to 4,608,000 injections. Now, of course, that's everything. Brotox, filler, polynucleotides, whatever. 4,608,000, and according to this article, 1,000 complications, of which most of those, but we don't have the full number, are probably bruising.
And what's that as a percentage?
That is 0.02%.
Right. Okay.
So, again, I'm not here to say that's good, we should tolerate complications. I'm not saying that, but I'm saying the gravity of the problem versus the seriousness of, I guess, the implications of some of these articles is questionable.
Yeah. Okay, and then maybe let's play devil's advocate. And again, I'm just putting myself on the opposing team, I want to say team, opposing viewpoint. Some might say, well, not all complications are reported. It could be way more than that.
Correct. And that is true, but I guess you would have to assume if you had a serious complication, a blindness, a serious necrosis,
a stroke, a death,
that would be very hard to not have surfaced. And gone to the TGA and the patient maybe even complain against the practitioner. It would be highly unlikely.
And then, okay, so we can assume safely that all serious complications probably become known at some point. So there's probably not too many more unknown, significant, dangerous complications that haven't been reported. Correct. But there might be many others of bruising, I'm not happy with the aesthetic outcome.
I'm sure there are, because even though I can qualify with my patient and document the notes, you bruised badly last time, I'm very sorry, let's try not to do that again. Yeah. It's the same risk every time.
And just for any sort of lay people, and I'm one of those lay people, that to give more context around things like bruising, like you might have a medication, like you might start taking fish oil, for example, which it makes you more prone to a bruise. Maybe your skin's become thin. Maybe you're using something that like a vitamin A that potentially could thin your skin out potentially. Other medications. The aging process itself, the older you are, the more prone you probably are to bruising because you just, the skin's thinner. So there are factors that can increase your risk profile that are completely out of control of the practitioner.
I'm way more realistic with my patients. I'm like, look,
expect a bruise.
I'm going to do 25 jabs in your face today. So 7 or 9 for your glabella, 10 or 15 for your forehead, and maybe, 8 per crow's feet. There's a lot of injections. The chances of you not bruising are minuscule. You're probably going to bruise. And that's not because I'm rubbish. It's not because you're a difficult patient. It's because I've put a needle in your face. And just like you said, by some miracle, most of my patients don't bruise at all, but occasionally they do.
Yeah.
If you just think about this as medicine and not magic, complications, or inverted commas complications, are going to happen.
Yeah.
And also, they're not a rarity, or they're a rarity, but then it's not bad medicine.
No.
It's not necessarily bad practice. But the insinuation from this is bad medicine.
Yeah. And complications happen with everything, really.
Yeah.
And to be fair, clinics aren't doing this, they should, but I think the overwhelming majority would. This is something that's very clearly outlined in a consent form.
Including Dr. Delaney in the 52-second video, he mentioned bruising, swelling, muscle weakness causing an eyebrow drop.
Yeah.
He mentioned that.
Yes.
And the patient consented and said, proceed. I can't remember what they said.
So he mentioned it on the phone call, and this is something that I think most people are pretty, this is something that's happens I wouldn't imagine that it doesn't happen, that this is also signed physically as well, that people sign off and say, I understand these are the risks that are associated with this treatment and I still want to proceed and here's my signature.
Yeah. Now, just to take the other side of the coin, informed consent means you actually understand what's being said to you and you've got time to reflect on it.
True.
And you're given the pros and the cons and alternatives and all the rest of it. Now, again, we don't know the context to this patient, because we don't know whether they're a new patient, a returning patient, whether they've gone through this process a million times before. In practice, in real life, when I've consented patients both for major operations and Botox, the principles of consent are the same. They've got to believe what you say. Sounds crazy, but by law, they've got to believe what you say.
Yeah.
So I was in a situation once in the UK where we said to a gentleman who had a really bad diabetic foot, essentially, we need to amputate. There's no way of salvaging this, and we need to prevent this getting worse. Otherwise, you're going to lose more. And he said, that's all fine. I hear what you're saying. I just don't believe you. And so we got into this kind of situation where we couldn't do what we wanted because the patient wouldn't consent because he didn't believe us. But anyway, he didn't do well.
Yeah.
But there are nuances to consent, but that's one. But also they've got to understand what you say, retain it, reflect on it, and make a balanced decision, what a patient has to do.
Okay. So maybe just a tip from my perspective, if I was still a clinic owner now, which I'm not and probably won't ever be again, why would you not get your patients to maybe to fill out a quick quiz at the end of a consultation process to make sure that they understand? Because the amount of instances that I've seen where patients say, I just signed that, I didn't read it. Well, okay, I don't know what to do with that information. Now it's getting to the point where you actually need to say, I want to make sure that you understood what it is that I told you. And it's not because patients are silly. Sometimes they're just anxious about a treatment. They're not thinking about it. Yeah. They didn't have enough time to process it. But if you just have a short questionnaire at the end of your consultation, which would then demonstrate that, yes, I understood there'd be bruising and I wrote that down, or I ticked that option that I understood. Maybe that's something that people could implement to further secure or to make themselves beyond reproach.
I'm not disagreeing that if there's a better way of doing it, we should look at that. But this doesn't happen in hospital for major operations.
Yeah.
And I don't know whether the dentists that I've ever seen are the rarity. I've never signed a consent form in my life, whether UK or Australia, for stuff that's done to my teeth, such as drilling holes in them, putting composite bonds on them, doing injections in my gums. I've never seen a consent form.
Yeah. I agree with you, but it just seems like for whatever reason, and we'll get into this industry, attracts a disproportionate amount of attention and sensation. I'm not saying this article was sensational, but I'm saying it historically attracts a lot of sensational articles.
Sure.
And so if you know that your industry is constantly in the crosshairs and you're one mistake away from ending up on the front page of a newspaper, then rightly or wrongly, maybe you need to do more because that you're a high target profession. You're in a high target.
Doesn't matter what the regulations are, and me and you were talking about this yesterday, I think we should always hold ourselves several levels above that. And doesn't matter what someone tells me, I want to be better personally every day. But I also don't think we should change the model of medicine that is accepted everywhere in the world and start introducing quizzes and random stuff that someone will poke holes in and say, that's not standardized. How do you know that's evidence-based, et cetera, et cetera, et cetera.
Yeah.
If someone's got a problem with this, they're not going to let go. Doesn't matter what you do, they'll find holes in it.
Yeah.
But sure, I think we should all try and be better. Absolutely.
Yeah, I know surgeons used to do that, or still do it.
Really?
They'll get patients to sign. They'll get them to do a quiz at the end.
How interesting.
Yeah.
I'd like to see that.
Yeah. Yeah. In the aesthetic space, surprisingly.
Yeah.
I'm sure this scrutiny doesn't come on to cardiovascular surgeons or neurosurgeons. I don't know. So in summary, what do we think about the article? I don't want to offend anyone here, but if we just look at this unbiased and as unbiasedly, is that word? Unbiasedly as possible.
Yeah.
What do we think? They're talking about a problem. Okay. Context.
Look, again, we have to try and do this as journalists ourselves with podcast hosts. And I've tried to say at the start, we do try and balance things. But look, this is an interesting article for the public to at least think about.
Yeah.
Do I think that there needs to be a lot more context? Absolutely.
Yeah.
Do I think that they need to have a few more commentators to balance the view?
Yeah.
Yes, including mainly nurses who are actually implied in all of this.
Yeah. And maybe data.
Yeah, scrutinizing the data rather than just giving a number. Okay, so 1,000 complications out of how many treatments? Because that gives you context.
Yeah.
If I said to you, 1,000 people die every year on the roads crossing the road.
Yeah.
The knee-jerk reaction will be, well, we can't cross the road anymore.
We'll ban pedestrian crossings.
Yeah, it sounds stupid, but that's the same thing, right?
Yeah.
But how many people don't die? How many people cross the road? I don't know, millions, billions.
Yeah. Or have adverse effects to other medications, even something as potentially... It's not benign when you take enough of it, but something like a Panadol, which you can buy over the counter without any doctor oversight.
Yeah.
You know. So, okay. So further context.
What are your thoughts?
Yeah, look, I mean, I've been around the industry for a long time, and these things seem to come in cycles where you'll get something happens, like that situation with that person, and this is something we didn't talk about as well, like people that aren't even doctors or nurses who are masquerading as such and maybe using black market product that story with that patient that died from the filler injection, or it was basically the way the story was written, and I don't even remember who the journalist was back then. The way the story was written was implying that it was a nurse. I think the nurses got a lot of scrutiny over this, and I don't know why, but basically it was someone who was pretending to be a doctor who was doing aesthetic treatment but actually killed them with overdose. I think it was tramadol.
Yeah, like a painkiller.
A painkiller. And all of a sudden that led to a whole cascading series of events that basically implicated nurses and brought a lot of scrutiny in their direction. It was nothing to do with them at all.
Yeah. I guess they get swept up in the reaction from the regulator because, one, 90% of them happen to be nurses, and two, that there was a whole scrutiny of everything. Where'd you get your drugs from? How are you storing this stuff? And yeah, because 90% were nurses, maybe just by definition they felt victimized. I don't know.
Yeah. And maybe just to sum up, I don't know if anything in that article said that what was happening was illegal. As far as I'm concerned, or I'm aware, and I could be wrong, that most people are working within what is legal.
Yes.
So I think most people try and do the right thing. And I think that people that are, whether you're a doctor or a nurse or a prescribing doctor, if it seems like people are following a process that they've clearly had legal advice on and the regulators are there, these things get reported. Most people are working within what they think is an acceptable, safe framework.
Yeah. One question that I have for the journalist, and
we did ask him to come on.
That's true. We did ask him to come on. And to be fair, he said, look, I'm not the story. I'm the writer in a newspaper column, and my job is to research and I guess be the messenger. And fair enough. Why comment if you don't feel like you can add more value? But I guess my question is, when we do podcasts, and we've done nearly 300 now, I would guess 95% of them have a specific purpose, a reason, an angle, a reason why we're covering that topic. Now, sure, if you read this as the public, you'd think, well, there's a really good reason to expose this or talk about this. But I don't really get how and why now, and also the slant without balancing it. That's what I don't understand.
So then I guess it raises the question, as you said, like, what is the intention and who's behind? Yeah,
exactly. We're never going to get the source, and to be honest, I don't want to know the source, but clearly there is a source.
Or sources.
Or sources, exactly. And this kind of gets back to the lobbying process and the political machinations behind the scenes as to what is actually going on. Because we know that new regulations are going to come in about a month's time or so from APRA, and maybe they'll be positive in a way, maybe they'll be more punitive, who knows? But the idea that I feel like these stories are dropping to bring attention on new regulations are coming, and maybe, I don't know, maybe they have insight into what the regulations are and they don't agree with them. I have no idea.
Yeah. By the way, before we move on, that advice that I gave around adding a questionnaire, talk to your lawyer and maybe talk to your medical insurance company before you do that. That's just an idea that I've seen implemented. Get professional advice before you take my advice.
Yes. Okay, fair. All right. The next article was called "You're a Pretty Girl, but How the Injectable Industry Preys on Your Insecurities." Now, again, taken at face value, I thought this was reasonable sort of commentary on what may happen in an individual clinic on a certain day. But the generalization, I feel, is a bit unfair. And what were your initial thoughts reading this paper?
Same as you. Of course, there are instances where people probably get consulted in a way that's not appropriate. They go in with a concern A and get told they've got all these other things wrong with them. There are definitely elements of body dysmorphic individuals who either get intentionally preyed upon, or they just see someone that hasn't been trained appropriately or doesn't have the soft skills, the consultation skills, or the general experience to say no to certain things. But body dysmorphia is an issue that goes like well beyond what happens in injectables. If you just look at social media, if you look at like fashion,
women's magazines, dieting, food.
Yeah, Victoria's Secret. There's a whole sort of body dysmorphic element that's out there in the ether that goes far beyond what injectables do. Yeah, I agree that in cosmetic injectables and cosmetic surgery, which is permanent, definitely can contribute to this. But it seems like it's always identified as the reason why. And I think it's a symptom of maybe social, mental health issues for people, the way that they're being. The reason that people potentially could develop this is probably what they're seeing on social media, more so than having an unscrupulous, unskilled person giving them a consultation. That's just my high-level view on it.
Yeah, just a bullet point. So name a patient called Jas Rawlinson. She never worried about her face's symmetry until a cosmetic nurse interesting. A nurse pointed out asymmetry during a visit to the clinic, and the nurse's comments led her to get Botox prescribed by a telehealth doctor in a brief video consultation. So even just those two sentences, highlighting nurses, highlighting telehealth, highlighting brief consultation, it seems to be augmenting the previous story in a way. I don't know if it's written deliberately or not. But I guess the point is, can cosmetic consultations be done in the wrong way that make people have treatments they never need or make them feel worse about themselves? And sure, that can happen. That's a reality. That's why we try and take a history. I noticed in this article, maybe I missed it, but I didn't see it, that last year it was now mandatory. We have to have a screening questionnaire to highlight and identify body dysmorphic patients. That's not mentioned here. And yet that is now law. Both non-surgically and surgically, when we see patients, we've got to do this mandatory. So that's something that we have tried to cater for and identify, and it's not something you can avoid now.
I guess, and is aesthetic medicine or cosmetic injectables a symptom? Like people getting treatments because they already have body dysmorphic issues that have been caused by just society these days, and the expectations of people that can develop, or people that start to develop unrealistic views of who they are. Like even just we had on Dr. Shahidi many years ago, who's probably the leading rhinoplasty, or one of the leading rhinoplasty surgeons here in Australia, is an ENT surgeon. And he was saying that, like, just the fact that people can take photos of themselves from like different angles, different lighting, that has changed his whole consultation process. And so is it iPhones that are the problem? Is it the people that is it the issue that people have cameras on their phones now?
Look, we saw during and post COVID.
The Zoom dysmorphia. Yeah, true.
It's absolutely a phenomenon that I think even you and I would agree with, because we suddenly went on Zoom and we're like,
I used to think I was good looking.
Yeah, I look terrible, my hairline's going, whatever, I look fat. I think that's a very, I don't want to use the word normal. It's a very human experience to scrutinize yourself in some way.
Yes.
And I actually talk about this explicitly with my patients in their consult. One, because I will take photos, and I will often say to them, I know you're not going to like your photos. It's okay, because I don't like my photos either. I try and normalize it. But if we're going to do our due diligence and examine a face properly and recommend the right treatments, we do have to document it, and we do have to talk about the face.
Of course.
So how that's done, rather than just doing it, would make someone either feel supported or judged.
Here's the thing as well. In the previous article, it was criticised that a consult lasted 52 seconds. So if you're doing a 52-second consult, people say it's too short. If you sit there and do a thorough consultation with someone and say, look, I know you've presented today with hollowness under your eyes. Let me just explain to you what's going on here. There's an aging process that's taking place. That hollowness under your eyes is happening because a fat pad that used to live here now has sunken down here because you've had collagen loss, and this is just the aging process. We live in Australia. We've got a harsh sun. This is just the process.
You awful doctor. You've judged them and you've upsold them.
Yeah, and it's like you're damned if you do, you're damned if you don't. If you give too brief a consult, then you're just rushing people through and not being medically responsible. If you do a proper consultation and do an overarching assessment of what's actually causing this, because now we're saying it's bad for you to talk about the issue. Like, it's not always just as simple as here's the indication, I'm just going to put something right here and that fixes it. A lot of the time people don't understand. They might say, look, I'm worried about the hollowness under my eyes. It's like, actually, it's not the hollowness under your eyes that's the issue. It's something else. I just think it seems like no matter what you do, you're going to get criticized for it. Otherwise, you do a thorough consultation and explain things. And maybe it leads to other treatments that they hadn't recognized, or they thought that it was issue A and it's actually issue B.
Correct.
Or if we do this and we don't do this, that problem's going to become more obvious. If we freeze your forehead and we don't treat your frown lines, you're going to look unusual. You're actually going to hate me more.
Let's give this context of awesome balance, because you and I have observed or trained people where they do it in a very horrible way, and they do pick out flaws that people never came for, and it's done in an awful way.
You're here for your chin. Have you seen your have you seen your nose?
Jokes aside, we've all seen that, and it's not good consulting, and it's not how we train, and it's not the norm. I would strongly suggest it's not the norm. But you know how the sort of article is written, it suggests that this is commonplace, and many people are going to suffer as a result of going to see an injector. That's how I took it anyway. We will be doing a podcast in the near future with Toni Picos. She's a clinical psychologist, and we're going to drill into this in a bit more detail. Don't take our sort of assessment on this to be gold standard. We'll sort of do our due diligence and get Toni on. But again, I felt it was real high-level bullet points that don't really drill down into the reality, perhaps.
Yeah. I think so. And it feels like there's an agenda to make aesthetic medicine seem like the devil's work. And with everything, there are bad lawyers, there are bad barristers, there are bad judges, there are bad doctors, there are bad everything. You're always going to have an element of bad actors, poorly trained, people that are unscrupulous, sociopaths that don't understand that human empathy is a real thing and, that they only think about themselves. That's going to happen everywhere.
Yeah.
But if you look at the number of people that are undergoing treatments, if this was like a systemic major problem that was damaging society, I think there'd be a lot more indicators and people wouldn't keep coming back. There'd be more complaints. The industry just seems to be growing.
Yeah.
And I think part of the problem is we've probably grown too fast to an extent. And this always happens when an industry is going through that huge growth phase. Sometimes things get left behind that could have been done better. Some of the way that we're doing, the telehealth kind of thing. Yeah, maybe there's some ambiguity there. Maybe we need to do things better, for sure. And both you and I have been huge advocates for we actually need better training. Like, it's not acceptable to send someone on a 2-day course and let them go off on their own. That's my personal view. I know you agree with that. Yeah. So if we want better outcomes, rather than just attacking and potentially taking things out of context and not providing balanced opinions, I want to get to the source of the problem. Is this industry is not going away. Even if they got rid of all the nurses tomorrow, doctors are going to still keep doing it. If people can't get it done here in Australia, they're going to go overseas.
And the training will still be...
And so if your intention is to make things better, then the actions need to reflect that, which is we need better training. We actually need the regulators, and I'm not pointing any particular regulator and this is the complexity of as well, different regulators take care of different things. But if we want better outcomes, we need better regulations, we need better training, and we need to make people better at what they do.
Yeah, but I guess from anyone who's, if you like, anti-aesthetic, they will say, right now, the status quo is it is tolerated, the 1-day course is allowed, and you do have nurses and doctors who are consulting and treating subpar. That's true.
Yeah, it is.
It is a problem, but I feel like the focus of these, at least 3 articles, aren't really dealing with the problem.
No, they're talking about a symptom.
Yeah.
And, yeah.
Yeah, fair enough. Okay. Article 3. Brotox and slimming injections, thousands of illegal ads spruik cosmetic injectables. Now, this is probably, if you like, more valid, I think.
Yeah.
Not that I'm saying the other ones aren't valid, but I feel like this is probably more factual. We have seen since, at least in Australia, regulations were changed and covered the main things, but no prices to be advertised.
Yeah.
Before and afters need to be essentially not been done by medicine, and essentially not talking about things specifically like anti-wrinkle injections or fillers. You've got to talk about consultations.
Yes.
Anyway, we have definitely seen, and you and I, and these things get shared in our WhatsApp almost every day, examples of where this is not adhered to.
Oh, I won't mention the clinic. I won't want to call them out, but I'm in Bondi Junction nearly every day, and I drive past a clinic where the name of their business has got the word injector in it. I see it all the time.
Yeah, okay, fair enough. What this article essentially says is thousands of ads promoting Botox and fillers have violated the advertising laws. Advertising regulations prohibit terms like wrinkle-reducing injections, dermal fillers, or colloquial names like Tox and Brotox, which could promote prescription-only medicines. And essentially there's a whole ton of people not following the rules. According to this, the TJ removed over 2,000 unlawful ads in the last financial year and blocked over 150 websites in the last 6 months. Despite enforcement, no prosecutions were made, and businesses typically comply after a warning letter. Now, again, that's how it's supposed to be. You shouldn't be suspended or deregistered because you said Botox on your website. There's a formal process, and maybe you didn't even know it was there. Maybe it was a historical quirk that you didn't see. It could be a genuine mistake.
Yeah.
But sure, I think you and I can agree there's some deliberate, manipulative marketing campaigns to do this deliberately.
Of course, totally. There's always going to be that element. And the problem is that, for example, if you say that the speed limit is 60 and people are driving 80 or 100 and no one receives a fine,
you're just going to
I think people are going to continue to do what they want, or they're going to comply. Unfortunately, I think the problem is, and this is what I hear from people in some, I wouldn't say any let me just rephrase that. I hear this all the time, that someone's competitor is not complying and they have complied and their business has commercially suffered hugely because they're playing by the rules and their competition hasn't.
Yeah.
And so unless there is some kind of enforcement or there's a few examples made of people doing the wrong thing, then there are always going to be those that think, if I'm just going to get a warning letter, then I'll just wait till I get it. I might be able to get away with this for the next 6, 12 months, 8, who knows?
Yeah.
And then when they write me a letter, that I'll take it down. But during that time, look at the advantages I've had over my competition. And then me, if I put myself in the person's shoes that's complying, I'll be thinking, why am I following the law? I'm now financially suffering.
And also, why should you, as the person suffering, have to be the dobber, the person to go to the regulator and shout about it?
Yeah.
And potentially, I don't know how these things are anonymized or not, but potentially be found out as the person complaining.
Correct. So, to be clear, I actually, after much sort of toing and froing in my mind and having one, and this is, I like to think that I'm fairly open-minded. I'm happy to change my mind on things when new evidence is presented and it's compelling. I was, you guys are nitpicking and leave us alone with advertising. And I've come around to think it's actually probably a good thing.
Yeah.
I think that it has put the balance of the power back into the hands of the practitioner so that they're making the right recommendations. People aren't picking out treatments like they're on a menu, not being able to encourage people through cheap prices and promotions. I think on the whole, it's probably a really good thing. So I'm on board with it.
Yeah.
But my criticism is that it's hard for people to feel like it's fair when people are not complying and there seems to be no consequence for them.
Yeah.
And so then you think, why should I comply? There's nothing happening to my competitor. I'm losing all this money. I'm now, I can't, I'm struggling to feed my kids. I'm struggling to pay the rent. The cost of living is astronomical. It's
we did ask Jason this when he came up from APRA, and I felt like, I don't want to wrongly paraphrase, but I felt like what he was saying is there's a period of
a grace period.
Correct, a grace period or a period of observation to see what sort of happens after the rule has changed. Yeah. And I strongly suspect whatever happens in the next month or two with new announcements, there'll be a more serious clamping down. It's been about a year now, I think.
Yeah.
And that's actually fair because it gives everyone a year to get their shit in order and tidy up their website and do as best as they can. You can't change this overnight. I was like, bloody hell, like, how am I going to change everything that I've ever published on Google overnight? It's not possible.
Yeah.
There'll still be instances, I'm sure, where...
Oh, you've got a page in your website that you weren't aware of.
Yeah, very difficult. You might have 200 pages on your website.
Yeah.
Yeah, it's a tricky one. But sure, I think what's said here is factual. There are lots of people deliberately...
Yeah, I saw one of the instances, I can't remember where I saw it, but there was someone that was advertising, or maybe it was in the article, they were advertising on the back of a bus.
Really? Yeah,
there was an advertisement of someone doing an inappropriate advertisement on the back of a bus. And I'm thinking, that's so blatant.
So what should we do about it? Forget the article. What should APRA or what should we as practitioners do? Do you think, I mean this is a really...
Is this TGA or APRA?
TGA manage the advertising.
Yeah.
It's not APRA, I guess, would only get dragged in if there's a professional issue, but the TGA manage like the advertising of drugs, etc., and importing as well.
Yeah. I mean, what would I do? I think that there needs to probably be some communication to say, okay, you guys have got a month from now. From then on, there will be fines issued, significant fines if you do not comply. And then there will be some people that go, they're bluffing. They need to be probably made an example of. To be honest with you, unless people see like people would go around like stealing cars and breaking into people's homes and murdering people. If you didn't go to jail, if there's no law, there's no rule that says you can't do these things and there isn't a consequence and people actually don't get punished for it, then people will just carry on, unfortunately. That's just human nature.
Yeah.
What do you think?
Look, I won't name them, but there's a very well-known person, I won't even say doctor, nurse, whatever, who is revered for his knowledge and he's huge on Instagram and he seemingly speaks about this stuff very openly, like drug names, and seems to get away with it all the time. So I don't know how some people seem to get away with it. It's so blatant.
Yeah.
And others who accidentally have a word somewhere in the 900th page of their website get a fine.
And there are also some people, a few doctors in particular, that are very vocal about nurses being bad and they should be eradicated from the industry. And I'm not going to say who this person is, but if they're listening, I'm sure they know who they are. There's instances and screenshots of them in blatant breach of the law, which is quite rich.
Yeah. Anyway, look, again, it's not for us to judge what people do with their businesses, but there are laws. I guess what we're saying is understand the law. You might not even know what you're doing wrong.
Yeah.
I'm not saying that everyone is being completely, deliberately flouting the rules, but you really should know what you can and can't do.
Yeah.
In fact, you've had long enough to try and understand this stuff. I would be still keen to understand that what actually happens with before and afters, because many patients have voiced to me quite recently, actually, they said, you know what, I know there are law changes and I understand you've got to comply with this stuff, but the one thing that you used to do, which you don't because you've taken it all off your social media, is before and afters. Because I'm not stupid. I understand that a different face is a different face, and what you did on one person may not be applicable to me, but I will understand the general concept of a filler in a part of a face, like a nose or a chin or whatever.
Yeah.
And that would actually help me understand what I'm signing up for, not just come almost blind and hope for the best in a consultation. That does, I think, need to be tidied up, because whatever we are offering, it's aesthetic outcomes. It's tangible, black and white change, even if it's subtle.
Yeah. It's difficult, isn't it? Because there's an argument both ways. As you said, there's the argument that you're almost inadvertently soliciting through photos, and you've got all the people that just, they take terrible photos.
Then they're in breach of the TGA regulations for not doing compliant photos. That's a different topic.
Yeah.
The point is, if there is a standardized way of doing something and that's expected, and you can do that educates the patient and makes their decision more informed, why would you not allow that?
Yeah, it's interesting. If I walk past Dan Murphy's, the bottle shop, they got advertisements all over their shop front around 5-6 cases of Merlot and I don't know what that, but there's always promotions going on for alcohol.
Yeah.
I would say alcohol does probably far more damage to society than...
No, it's not a drug, but you've got like McDonald's sponsoring the Olympics, and there are many ridiculous examples of the hypocrisy in protecting the public.
Yeah. With
probably way more damage than what we're doing. But anyway, I appreciate we all need to tidy up our own house and be as good as we can. But let's hope these new regulations are useful.
So, I mean, let's summarize our position. We don't want to sit here and criticize the journalists, because I'd like to think that most people get up every day and want to do the right thing.
Yeah.
I think that we probably, if I had to critique it, I think maybe just some further context. I think giving a more balanced view, allowing people from the other side of the discussion, and maybe they asked them and they refused to come on. Maybe that's the case, and if that's the case, then and I apologize for having the incorrect assumption. But I think more context, both sides of the discussion, just more balanced in general, I think, and maybe less sensational and more factual. What do you...
Here's a thought. As a journalist, you're damned if you do, you're damned if you don't. I think that the fact that, focus has been put on industry is a good thing, because like I said, we want to be better. Yes, like you said, I think there's nuance that would make this a little bit more understandable and balanced. Yeah. If you're listening to this and you either do or don't agree, it's not for us to judge. Contact Clay. He's on LinkedIn, Clay Lucas. You can just look him up, because his contact details are there, and he seemingly will be publishing more and more stuff. So if you want to balance this, get your story in. Tell him from your perspective. It's not our perspective that counts, it's yours. Yeah. And maybe we'll see other sides of the story published. Who knows? Yeah.
I think it's important. I think if you are going to present an argument or run stories, and if, as you said, there's going to be more in the future, that it is balanced. I think it'll give more credibility. And I think there was a lot of criticism coming in the direction of the regulators around some of the changes because of some of the webinars that happened. And then we had Jason that came on and he spoke so eloquently, and the amount of people that have spoken to me and said, wow, I actually have a whole new level of respect for the regulators, because this guy was articulate. He understood the industry. He understood what we do. He seemed like a common sense kind of guy. Yeah. And I actually have a lot more respect for them now. And that's an example of people wanting to do the right thing, but just wanting to be heard, wanting to be understood, and actually have people that are making decisions or writing stories that appear, at least, to have a broad understanding of the issues.
Yeah. Now, obviously, we've focused, understandably, on Australian stuff happening. But like I said at the start, I've heard in America there may be major changes in Texas, where the way it was described as mid-level providers, so nurses, nurse practitioners, and PAs won't potentially be able to inject anymore. It's a huge thing if that happens, and it could potentially spill to other states. It would be like an example state that then other states follow. So if you are involved in any of that, either side of the argument, let us know, because we'd love to do an episode which is more less Australian centric.
Yeah, exactly. The trend is that industries coming under scrutiny, and no matter where you are in the world, there is likely increased regulation heading your way. That's the trend, because the industry is now big enough that it's got that much attention.
Yeah.
And there are things that do go wrong, and there are bad actors, and there is huge amounts of money involved. It's only a matter of time. So yes, it's happening in Australia right now as a hyper-focused issue, but it will spread because the industry is everywhere.
Yeah, and certainly the UK, things are rumbling there as well.
Yeah, okay.
Great. Thanks for the chat, buddy.
Thank
Hopefully
you.
that was as clear as mud.
Yeah.
And we'll see you in the next episode.
See you guys.
For our latest news, follow us on Instagram at Inside Aesthetics Podcast. If you want to get in touch with myself or David, follow us on Instagram as well at Dr. Jake Sloane and David_Inside Aesthetics.
Join our Patreon for invaluable business and injectable education. Get access to our global community of like-minded professionals, live and interactive Zoom sessions, hints and tip videos, webinars, and more. Head over to www.insideaesthetics.com/Patreon for more information.